Okay, so hello and welcome back to the next part of the ARMA Thinking Differently for MSK Health Conference. I'm going to introduce the chair of most of the afternoon session, Jane Taylor. So Jane Taylor is someone who is living with MSK conditions. She is also a trustee of ARMA, which we are delighted to have her on board. And she is involved in so many things that I couldn't possibly list them, various patient organisations, including at European level, NICE guideline development, etc. So Jane, I'm going to hand over to you to introduce our speakers for the first panel session.
Thanks, Sue, and thanks for that great introduction. Make me sound far more important than I actually am. So it's a real pleasure to chair this afternoon's session. I really enjoyed this morning's sessions. I think that we got lots of interesting discussion on thinking differently. And one thing that started to come out was that I think if we're really serious about thinking differently and bringing about long-lasting change, then we need to do that with the people who are living with the conditions, and we need to be doing it in the communities who are affected by these kind of conditions, not just MSK, but other long-term conditions. And I think we've seen fantastic work, and many people today are involved in this work, not least some of our panelists. But we've seen fantastic work from the NHS during the pandemic, but we've also seen, sadly, some instances where things haven't worked out. And I think had we had perhaps more people with lived experience, and particularly more involvement from specific social groups in actually thinking about how to organise services, we perhaps would have had better outcomes. So that's why I'm really pleased this afternoon to introduce three speakers who are all in different ways working to think differently about how to co-produce change within the NHS. So without further ado, I want to introduce our first speaker, and our first speaker is Amy Herring, and Amy is a regional lived experience manager, and she works for the London and South East region for NHS England and Improvement. And Amy has a background in involvement. She's worked not just for the NHS, but also for a charity. But I think very importantly, Amy also brings her own lived experience to her work. She is an autistic woman living with long-term conditions. And I think that this experience probably helps drive her passion for personalised care and for supporting people with lived experience to be able to develop their skills, to influence strategic co-production and to contribute to lasting change. And Amy's given herself a great title, which is co-production, how to do it well. So no pressure there, Amy. But without further ado, I'll hand over to Amy.
Thank you. So hello everyone. It's great to be here at the ARMA conference with you all. Firstly, apologies, as we were talking in the break about tech. Unfortunately, I can't access Zoom from my laptop, so I have joined on my phone but have connected to my laptop. So I'll be operating the slides from the laptop, so I'll be looking slightly to the side as I'll be talking. So my name is Amy Herring. My pronouns are she, her. And as Jane was saying, I'm the Regional Lived Experience Manager for the London and South East regions within the Personalised care group at NHS England and Improvement. So for anyone who may not be able to see me for various reasons, my audio bio is a white female with dark brown hair. And I'm really happy to be here because it's great to talk to you about something I'm really passionate about that I see makes a difference to our health and care service. So it's great to have your interest in finding out more about strategic co-production, and I want to take you on a bit of a journey to understanding co-production. So I'm just going to start sharing my screen. Bear with me 1 second as I just begin to share this. So hopefully I'm now sharing my screen. Here we go. So welcome. So moving past the introduction slides, we have an image and a piece of text I found within an article called Shared Responsibility for Health by the King's Fund. And this came from Sir Chris Ham, and I have included this in here because I think this demonstrates why we need to look at the responsibility for improvement as a shared responsibility. So creating the conditions for co-production requires a cultural shift to recognise the impact people with lived experience bring. People are bringing more than their experience. People are bringing their insights and expertise with a passion to create change and support our health and care system to be the best health and care system, ensuring people receive good personalised outcomes. And this graphic at the bottom demonstrating feeling powerless against a complex health and care system, shifting to working in partnership with health and care professionals and sharing power is part of a wider graphic called the shift in relationship between patients and health and care professionals, which was developed by the National Strategic Co-Production Group within the Personalised Care Group at NHS England. And what this shows is that cultural shift. Although this applies in the context of receiving a service, it can also be applied to think about how we co-produce with people being recognised as active partners within conversations and decisions at a strategic level to co-produce, whether that is services, new support available, strategic vision and more. But then also that shift around working in partnership, sharing power, which is what I want to talk about a little bit more, and which is the article I have referenced, which goes into a lot of detail about how we share responsibility and work together to support and improve our health and care system, ensuring people receive care and treatment that is personalised. Lastly, I just want to touch on the second part of this reference about leadership. Leadership in people with lived experience is something that has grown over many years and has been recognised as being incredibly valuable in people with lived experience and has shaped a lot of change. Leadership is not a position, it's an action and example. And I have seen a lot of people with lived experience bring change and leadership to create a health service that matters to them and their peers. And I'm delighted to see a few people who I recognise at this conference as leaders and particularly bring lived experience leadership too. So please make use of networking at this conference with these individuals to learn more about how people have enabled the culture for co-production within MSK services, and also make yourself known in the chat box too. So in terms of creating a level playing field, the lived experience team at NHS England and Improvement have created the peer leadership development programme to provide that investment in people. And in many people, we invest in them to develop their knowledge, skills and confidence, but opportunities to be invested in do not often exist from the perspective of a person with lived experience who is involved in co-production. So investment in people is a key enabler to support collaborative working and leadership, as mentioned in the last sentence on this article. So investment in people is also something recognised as a practical step to co-produce in ICSs within recent ICS implementation guidance, working with people and communities. And particularly it was recognised that the peer leadership development programme is an enabler to this. So I'm just going to see if I can move us on to our next slide. Brilliant. So moving over to this next slide about impact and to explore in a little bit more detail. We often know co-production, when done well, creates an impact, but what is that impact? When we talk about when we have co-produced alongside people, what is it we're capturing and evidencing within that impact? So within the lived experience team, we've noticed some themes within the impact peer leaders are creating. And here we have impact. So impact stands for insight, modelling, proof, active, champion and true to purpose. And along with the descriptions of each of these areas, we are able to recognise the change people with lived experience can bring and why people with lived experience are crucial to how we adapt our health and care system moving forward. There's been a lot of visible impact within MSK services, particularly in relation to personalised care such as supported self-management and social prescribing. One thing I've noticed that we're really good at is producing reports such as progress and highlight reports. but I often rarely see anything that mentions where something has been co-produced or that demonstrates where people's lived experience has made an impact or difference. Often it's the question of following up and asking, where was lived experience in co-production? And often the answer is, we co-produced this with people. That's great, but that's just the tick in the box that says you've co-produced. And sometimes when diving into the detail of the how and the outcomes, it actually hasn't been co-produced. There's a whole lot more we can do to demonstrate lived experience within our governance and decisions. And as a starting place, it could even be ensuring that in regular reports, there's some information and detail about co-production and how there was collaboration with people with lived experience. But I recognise and appreciate it can be hard to think about how do you show the impact of listening to what matters to people. But this impact template is a good starting place to begin thinking about where people with lived experience were truly co-produced with. And we sometimes use this within our team as a tool to capture and demonstrate the impact of peer leadership and strategic co-production. And we do have a template version of this. So if you're interested in learning how to use this framework to capture impact, then please feel free to get in touch. So I'm going to move us on to our next slide. So we've got this lovely image just about the importance of sharing responsibility through co-production and what the impact is that can create that change. But before going into detail, is that co-production is different from engagement, such as surveys and focus groups. Engagement is as equally important in capturing and listening to what matters to people, but it's not co-production where we're sharing responsibility and working together to create change. So engagement is as valuable as co-production, but they're both different, and engagement is great at capturing the views of a large community, but it's not collaboration, which is almost and probably part of the core of co-production. So we have this quite informative model put together that looks to capture the ingredients for co-production. Firstly, it's really important to facilitate this process. A lot of this aligns to the Integrated Personal Commissioning Guide from NHS England and the Local Government Association a few years ago, but it's still very relevant today, and was also featured as a practical step for co-production in ICSs within the recent ICS implementation guidance I referred to just a few minutes ago. So within our first inner circle is a process of gaining commitment and leadership from either your team or organisation to co-produce with people. Then is contacting and connecting to people with lived experience from different communities to ensure we're reaching out to people from different backgrounds. And then building the knowledge, skills and confidence to ensure we have equal knowledge, skills and confidence, recognising that not everyone knows about commissioning, not everyone knows about how change happens. And without this knowledge, it can often feel like a different language is being spoken about, and it can feel quite disengaging and disempowering too. So, and then we move on to creating that common purpose. And this is important as this ensures good co-production and helps to avoid tokenistic involvement. So have a clear purpose that you can communicate to people, and that supports the aspect of collaboration, which I've been talking about quite a bit. So co-produce and then also review impact, which I spoke about earlier. And the Best MSK programme is a great example of showing the commitment and leadership, but also creating that common purpose. And there are some other examples already mentioned within personalised care. Also, just a shout out to the work at the Camden Pain Clinic and within Sussex, both which I recognise as quite clear, tangible and visible examples of good co-production happening with the health and care system. But then in the outer circle are some of the elements that support and sustain that culture shift needed. So collaborative relationships requires time and trust, and we need to build this with people. And hopefully you can already begin to think about how engagement and co-production are not the same when we talk about shared responsibility and the shift needed to improve our health and care services. Interesting, we talk about ensuring equal power a lot, but when looking at the detail of what isn't equal, we see the difference between personal and positional power. We can't avoid that there will be people who have accountability and responsibility or learned experience through their positional power, but that positional power is outweighing the personal power people bring, and we need to get this balance. The lived experience is as powerful as the learned experience, and the lived experience brings something different that the learned experience can sometimes not often bring. We still need to recognise and address this power imbalance, not only when co-producing services or support, but also in the workforce, where we have peer support workers and lived experience practitioners. So facilitative leadership is essential to this and is at the heart of this approach. So good facilitative leadership will ensure balance of power and will ensure people have the right opportunities to influence change in the areas of going where the energy is to support meaningful co-production. Good facilitative leadership will also pay attention to how decisions are made and how change happens too. So moving on to diverse representation and different understanding the importance of different perspectives are for creative problem solving and innovation. One common thing I often see when people are recruiting for patient or carer representatives is sometimes the requirement for previous experience. And sometimes I actually often see the words something like board level experience required. And the need for such requirements is such a huge problem and is often the contributing factor to a lack of representation from certain communities. We're working with people who have long-term health conditions and disabilities, or who might have full-time caring responsibilities. So some people may not have had access to these opportunities previously. I won't go into detail, but we know across sectors, board level representation is lacking from various communities. So expecting people to have such previous experience is not realistic if you want to work with diverse communities. And when there are such large requirements, skills, or experience needed, we psychologically know that people might be put off by this. But investing in people's knowledge, skills, and confidence supports people who may not have co-produced before, or who may not have had access to different opportunities to develop their knowledge, skills, and confidence. So supporting them to become confident to work with the health and care system. And finally, the role of co-production groups brings people's voices together into a collective and stronger voice. And this is underpinned by good facilitation. And through this approach of strategic co-production, there isn't one right way to co-produce with people, but a lot of this I see within some of those really good MSK examples I was just sharing earlier from within Camden, Sussex, but also reflected within the Best MSK programme. And I'm sure there are lots of other really good examples, as that leadership around lived experience is something that has been recognised within MSK for quite a while and a long time. So moving on to the last slide, there's some further information here to check out some of the resources I mentioned, but I appreciate there was a lot to think about here. I would not expect people to immediately start all of this, but a mantra I often use and reflect on is not practice makes perfect, but practice makes progress. This is a journey that takes time and progress, and everyone will be in different stages, and that is okay. Some of you may be quite far into this journey, or just starting out, or thinking about where do you start. So the question I ask is, what one thing are you going to take away and do differently as part of that journey to make progress in ensuring collaborative, co-productive work with people with lived experience? It could be asking your team or organisation, what is the commitment and purpose to working with people with lived experience, or how are we demonstrating the impact of people to recognise and highlight the value of personal power. It could be finding out if you have facilitative leadership in place, or even as simple as maybe reviewing advertisements for when you are asking for people with lived experience to become involved, or even linking in with the lived experience team who can help you and support you in terms of investing in people's knowledge, skills, and competence to become more collaborative with the health and care system. So reflecting on what I have spoken about, Remember, leadership is not a position, it's an action and example. So what one thing will you do differently as a leader to ensure we are sharing the responsibility for improvement by working collaboratively to co-produce MSK services? I'd love to see some of these reflections in the chat, or if you're a tweeter, then to share your one action here, which might help inspire people to think differently, which is why we are here today. So thank you for listening, and please feel free to contact me afterwards as well. And I'll stop sharing my screen.
Thanks, Amy. That was a great introductory talk, and it's given us lots to think about. And it's also great to see people already sharing details and contacts in the chat. So do what Amy has suggested, and perhaps suggest one thing that you could do as a leader to encourage and to get people to think about co-production. So our second speaker is Sarah Smith, and Sarah is Programme Director for Improving Population Health for West Yorkshire and Harrogate Health and Care Partnership. And she's going to talk on the very important subject today, and one that really ties into co-production, and that is tackling health inequalities. Thanks, Sarah.
Thank you. Thanks, Jane. Thanks, everyone, for having me. I'm just going to try and bring my slides up now. Right, that should. Excellent. So I hope you can see those. So as Jane introduced me, I'm Sarah Smith. I'm a consultant in public health at West Yorkshire Health and Care Partnership. I'm Programme Director for our Improving Population Health Programme. Now, a big part of our programme and a big part of my day job is considering how we address health inequalities. I'm conscious this term can mean different things to different people, so just to sort of get us on the same page. We define health inequalities as unjust and avoidable differences in health outcomes between population groups. So here are some of the sort of key groups we consider when we look at inequalities. So often we can think about inequalities in relation to socioeconomic status or deprivation. We can think about inequalities in relation to health inclusion groups and vulnerable groups. We can look at protected characteristics such as ethnicity, sexual orientation or disability, or we can look at inequalities in relation to geography. And when thinking about MSK conditions, we see inequalities in all of these different population groups. So today I'm just going to provide a quick overview, sort of both nationally and locally, of some of the inequalities that we see in relation to MSK conditions, and then also touch on some work that we've been doing locally, both to understand and then to start to get underneath and address some of the inequalities that we see. So in relation to the geography in England, this is the spread of people reporting MSK conditions by our places. So the average proportion of people over 16 who report to be living with an MSK condition is around 18%, but this really varies from a figure of 10% in the City of London up to a quarter of people who are living in Sunderland. So there's a real variation there. And there are lots of things driving that variation, as I'll come on to. One of the biggest things that we look at in relation to inequalities in relation to socioeconomic status and deprivation. And one of the things impacting on this is people's ability to work. So when I was doing some preparation for this presentation, I had a look into the percentage of people reporting MSK conditions by employment status, and found there's a much higher proportion of people who report living with an MSK condition who are either fully retired, which you might expect in relation to age and the condition, but also people who are permanently sick or disabled in relation to their working status. So that's really important, because it could actually, not only might MSK cause inequalities or exacerbate inequalities, but it's also an action that workplaces could take to sort of help reduce inequalities as well. We see quite low proportions of people reporting MSK conditions in full-time education or in school. In terms of adult working age population, only 9.4% of people in full-time work reporting having an MSK condition versus 15.9% of the unemployed population. And that may sort of also be in relation to people being unable to work in relation to their MSK condition. So there's a really clear connection here between working status and people living with musculoskeletal conditions. Another piece of work that I looked at, which there's lots of details, I'd really recommend you having a look at it if you want to find out a bit more about inequalities and MSK conditions, is a report done by the Race Equality Foundation, and it has some lovely infographics. I've shared one of them here. And they looked at some of the conditions driving inequalities in relation to ethnicity and musculoskeletal conditions. They looked at what might be causing this, what are the physical factors that might be causing it, but also what are the other factors that we could actually impact on as a health and care system. So here we've got some of the conditions that might be driving that higher prevalence we see in some ethnic groups in relation to MSK conditions. So things like lupus and sickle cell conditions that might have a genetic link. But actually they also found a significant gap in evidence where maybe ethnicity isn't recorded well enough for us to really understand the inequalities in relation to conditions such as arthritis, joint pain and back pain, and also the use of medication that helps with those as well. So there's lots more we could do as a health and care system to help us understand these inequalities by ethnicity. And there's lots more we could do to address it as well. So they pulled out some of the key points around medication adherence and what more we could help, but also differences in cultural and racial attitudes to pain and long-term illness. And again, there's work we could do as a health and care system to become more culturally competent to address those. So there's lots of detail in the report that I won't go into today, but I'd really recommend having a look at that. And as I come back to kind of one of the biggest inequalities, as I touched earlier in relation to work and worklessness, but also the impact of musculoskeletal conditions on productivity. So this is something we can do in terms of working as health and care systems with employers to help address this and help employers understand the role that they can take to reduce inequalities through MSK conditions, because not only does it have a big impact on health, but it has a big impact on the economy. So that's some work we're doing locally around a Fair Work Charter, and there's certainly an element of MSK consideration on there as well, particularly because it will pique employers' interest because after cold and flu days, MSK conditions contribute the next amount to sickness absence. So in overall in England, we see inequalities by MSK prevalence, but you also see potentially that living with MSK as a condition could actually help sort of drive up inequalities in other areas as well. So in terms of locally, these are our West Yorkers in West Yorkshire and Harrogate. So this depicts our local population. These are 100 people that depict our population locally. And out of these 100 people, around 15 of those aged over 16 will report living with a musculoskeletal condition. And within that condition, in relation to health inequalities, there will be differences in how in the people living with the conditions and also how they experience care. So in relation to our ambitions as a health and care partnership, so as an ICS, we've got 10 big ambitions. And the first, and I think as I would do working in population health, most important ambition is around reducing the gap in life expectancy and also the gap in healthy life expectancy. And as many of you on the call might know, musculoskeletal conditions are one of the biggest factors that drive that gap in healthy life expectancy. So we see in West Yorkshire and Harrogate around 17-18 year gap in the years of life people can expect to live in good health, and people living with musculoskeletal conditions contribute a lot to that gap in inequality in life expectancy. So we started to think through what can we do about this. We did some work in 2019 pre-pandemic, and that was really looking at the intelligence. So what do we know about MSK conditions and how they present, and what more can we understand about health inequalities? And we looked at as a real kind of proxy for this, we looked at people receiving hip replacements in West Yorkshire. And we looked at this by deprivation. And what we found was that people living in our most deprived 10%, people living in areas in West Yorkshire that are ranked as the most deprived 10% of neighbourhoods nationally, were much less likely, after we'd standardised by age and everything else, were much less likely to receive a hip replacement procedure than people living in the least deprived 10%, which on the face of it doesn't seem to make sense, because living in a more deprived area isn't a protective factor. It's not going to stop you needing a hip replacement. So we thought there's probably something more going on here. So there was differences as well between our places. So the inequalities were more stark, for example, in the Bradford City Clinical Commissioning Group area than there were in the Wakefield Clinical Commissioning Group area. And while we couldn't at the time collect ethnicity data, what we did know is the proportion of people from Black and minority ethnic backgrounds in Bradford was much higher than in Harrogate and Wakefield areas. So we think there's a link that we'd like to look into more in relation to ethnicity in this data, as well as deprivation. These are the overall figures for the whole of West Yorkshire and Harrogate when we did the research at the time. And what these figures show is, if you look at bars 1 and 2, they're the people living in what are described as the most deprived 20% of our population. And you can see they're sort of statistically significantly different to people living in the least deprived areas. So what we can say overall is that people living in our communities ranked more deprived are much less likely to receive a hip procedure. So we did some more kind of work initially with clinicians looking at, well, why would this be the case? There were lots of factors that I won't go into in detail, but we've put up on this slide that we kind of hypothesised could be contributing towards it. But what I wanted to pull out is the impact of inequalities. So if people are not accessing hip procedures, does that mean they're more likely to be living with hip pain or reduced mobility? What we would want to look into more is links with opioid use, and more people on long-term pain medication if they're not presenting for a hip procedure, or are people on longer waiting lists. So there were lots of hypotheses as to why this could take place. And our next step that we're able to pick up now, and we're going to do some sort of targeted work in Bradford on this, is to look at a breakdown of the pathway. So each point in the pathway, we're going to be looking at what are the inequalities and why people don't make it through as far as a procedure. So is it that people aren't accessing primary care to report hip pain? Is it that actually they're getting the referral, but they're not able to attend their first outpatient appointments, they're falling off the pathway at that point? Or is it that actually they're on longer waiting lists, or they're turning down a procedure for sort of other reasons, such as socioeconomic reasons, and not wanting to or being able to take time off work? And then there's more we can do later on in the pathway, looking at the procedure itself and whether the quality outcomes are the same for our different population groups. So this is some work that we'll be picking up, and I hope I can share and report back on what we've found. Now, in all of this, there'll be a data piece, but also an engagement piece as well, both the clinicians and our wider population that it impacts on. But these are the next steps. We're really digging into, we understand there's inequality here, but what does that look like, and how can we help to address that? So I'm going to pick out now one of the points on the pathway, which is around supporting people on a long waiting list, and talk about some work we've done in the last few months, looking at how we could do that to address inequalities. So during the just post-pandemic, NHS England issued each integrated care system with a small pot of money to do some work on addressing health inequalities, which is such a broad area. And we thought, actually, we know we want to reduce the gap in healthy life expectancy. We know MSK is one of our biggest contributing factors to that. And we also know that there are inequalities in the length of time people are waiting in our area, both by ethnicity and deprivation. So we formed a Waiting Well pilot that we called, where we looked really at the gap between our service and our community. So when we talk about this, we look at that gap between our NHS services and our local communities, and what more could we do to bridge that gap to support people who might be living in pain on a long waiting list. And I don't know if people have seen the work of Professor Chris Bentley, but he often calls this the no man's land. And this has been a focus of our work over the last couple of years in the pandemic. And it's the kind of area that we're getting into with the vaccination campaign, for example. So looking more at working with the voluntary community sector, looking more at community spaces and venues, and looking at different approaches to help people in the community that move beyond the normal medical model. So that's what this pilot was based on. And we sought two areas that both fell in within Bradford. And within both the areas, we worked with a primary care network, and we worked with a voluntary and community sector organisation. So we set these two pilots up that were running sort of January till the summertime. And actually, I can say they're both sort of continuing in what as well, which is good work, because there's always a concern with sustainability with pilots, isn't there, as well? Both projects worked with the voluntary and community sector partners to engage with people on long waiting lists and kind of ask them what peer support they would want, what support they would want to manage pain in the community. And they looked at things that were different to what we might do traditionally in terms of pain management. So both looked at slightly different approaches. So Ease My Pain looked more at, there was online group instruction. So it was mainly online sessions, looked at craft and art and model making. And then they did some exercise sessions online. Modality, which is in the Keighley area of Bradford, they did a mixture of online and face-to-face opportunities. So again, they did some artwork, some cookery courses, and then some more kind of light physical activity, which actually getting people face-to-face gave people the opportunity to kind of socialise and share their stories as well. So they were the two approaches. In terms of output, here's some of the feedback and the lovely artwork that people shared. Both projects, we got some really good feedback, sort of case study stories from the patients, some real lovely comments from the second pathway about people feeling more confident in managing their pain. And with some of the areas, there was some kind of concern at first of, actually this feels a bit different for me, I'm not sure about this, but we had a lot of people who kind of converted into this way of pain management as well. And we also got some really nice feedback from the second pathway around a sense of community, and that helped them feel more confident in managing their pain as well. What we did find, though, is some interesting reflections, which I think would apply to a lot of Inequalities pathway. So I think additional work would be needed for some of the things that we hadn't anticipated around better engagement with some ethnic minority populations. So, for example, one of the venues, we got feedback from Bangladeshi women that actually that was more of a place that they wouldn't feel comfortable going. So there was a lot more we could do around kind of cultural competence there in terms of the feedback we got from the reviews. And there was a lot of experience of people previously saying these programs have been transient. I don't trust that it will continue and that will continue to get the support. And some learning around that takes a lot of time to embed new programs of work. But they've both been fully evaluated now, and there's lots of learning that we're able to share with similar pathways. So they're the outputs of the Waiting Well programme. I'm just going to finish now with this slide. So this was a comment actually from one of our VCSE colleagues who we're working with on the Waiting Well pilot, who said, actually, we're not looking at the low-hanging fruit here, are we? And it made us think, actually, you're right, we're looking at the kind of the top of the tree, the difficult to reach fruit. And this is a model we kind of adopted for our health inequalities work. And it touches on actually a conversation we were having sort of in the break around what's needed to address inequalities, and really at the sharp end is whole system redesign and really thinking differently and creatively about how we reach specific population groups. So part of that is understanding the inequalities in the first place and understanding who you need to reach. But then part of it is really working with communities and understanding what they need and how they would choose to access services and going out to them rather than expecting them to come to us. So we do a lot of good work in the NHS around sort of managing demand, and then bits around the edges around quality of care of people who aren't quite presenting. And then I think where we focused a lot of our inequalities efforts to date are on service improvement, so kind of tweaks to help people become more engaged, whether that be different forms of communication, etc. But actually what we really need to look at is that kind of top of the tree, difficult to reach fruit, as it were, whole system redesigned to focus on those with the most unequal access and outcomes. So this is something we kind of learned from the project overall, and something we're going to take forward into other health inequalities projects within the partnership. So I will stop sharing my slides there. Thank you.
Thanks, Sarah. That was great. Lots of really good examples there, and nice to see some creative examples as well, apart from the kind of run-of-the-mill initiatives. So our final speaker today is Craig Nikolic, and Craig has worn many hats in his working career, but he's currently Chief Operating Officer at a GP federation in East London. So currently, like many people, I imagine, very, very busy. But he's also had a 15-year career in the legal industry, and he is also a professional chartered engineer. So quite a useful person to have in a GP federation, I imagine. But importantly, also, Craig is an ex-serviceman who was medically discharged following significant MSK injuries. And Craig is going to talk about putting prevention first. So over to you, Craig.
Hi all. My presentation today, it's more of a talk rather than a PowerPoint presentation as we go. I am going to start this, and where we go. Right, there we go. My aim here today is to give a local view of putting prevention first. It's at a lower level, a more intimate level, down to the individual level rather than everything else. And it quite neatly follows on from some of the points Sarah raised there. But before I started, I had a look through the people who are attending here. There's a few people I know, so it's nice to see you all again, even if I can't speak to you. Maybe next time at a presentation we will. So this slide is about me, as is already covered. I'm a GP Federation Chief Operating Officer. GP Federations are at-scale general practice organisations. I'm also an NHS Confederation Network board member. I'm not a clinician, as said before there. I have lots of things. I'm not a lawyer, although I worked for 15 years in the legal industry. It was all about mergers, demergers, and doing big fancy projects around the world. It was then I came into the NHS. So I do have significant MSK lived experience, too many surgeries, countless days of physiotherapy. I do understand, and I do understand the issues that come from here. This is what I want to get out of this presentation, is to show you a more local view from the perspective of the NHS and an at-scale provider on this. I want to talk through the benefits of prevention to individuals rather than at system level. So it's the next step on from Sarah's, and it comes down to what can be done at the different level. And I'll walk you through what's there. I'll cover the examples just to put some context around it, and then I'll show you how you, as the people who are watching this, can become more involved. This is a call to arms, essentially, to get you involved. Because if you're not involved, who else is going to represent the people you represent? This is my view of what prevention is. This is not any official view, it's what I want out of prevention. We want to stop people becoming patients in the first place. That's a primary goal of prevention. The second goal is people who do become ill or have conditions, I want to stop them getting worse. As an NHS provider, if I can achieve those two, that allows me to take the scarce resources I have in healthcare to be concentrated on those who need the most help. To put that in mind, I have some context for you. I've used this image so many times in the last year that it helps me understand things. 2019, this picture on the left was things. You have life, you have issues, you come into the NHS, there's the big buckets of provision within the NHS. This is not social care. This is not the stuff that's done at VCSE level. This is just NHS. People fall through the gaps of planned care. They have unplanned and urgent care. They fall into the buckets of unplanned and urgent care underneath. Some people still fall through. You know this. You'll have seen them yourself. You'll have people who you represent and you help who have fallen through the NHS cracks. 2019 ended, we came 2020, and we added COVID into the picture. That has resulted in significantly more overall demand, but the supply is the same. The NHS buckets are the same size. There's been no extra people come into the NHS. So the demand is bigger falling through. So people you know who have needed healthcare have fallen through. They've fallen through into the urgent and unplanned care. And again, that bucket can only take them severely ill because it's overloaded. So that means the untreated pile of people here is bigger. If we can help by prevention, by diverting some resources to prevention, we could reduce the gaps coming here, or at least defer them into later life. And this is the overall goal. If I can reduce this untreated patients thing, bubble, my life is so much easier because I'm helping people and people are not going untreated. I'm going to put some context. Helping people avoid MSK, as was presented really well by Sarah, it's not just about deprivation. There are so many other issues. Like, for example, I work in Barking Dagenham. Barking Dagenham, the third most deprived local authority in England. Massive deprivation issues. I live in Suffolk, which is the other end of the world when it comes to deprivation. But there are still health inequalities in the most deprived, in the least deprived areas. For example, the rural deprivation of people who are too far away from health, or there's not the capacity, there's no easy access to a GP practice because it's 10 miles away, or a hospital's 40 minutes away. Completely different views of things, and it's different things. But I want to use just one example of obesity. This link is in the presentation, but you can find it as well yourself. The National Child Measurement Programme reported last month, and it showed, this is children. So reception year children, if you look at the difference between the indices of multiple deprivation, the least deprived children, this is overweight and obese, 19.7%, whereas the most deprived, 34%. And the same as year 6, it's 20% difference there. It's a massive difference. If you look at people who are severely obese, now this is 1.8% in the least deprived and over 10% in the most deprived. A lot of these kids are tomorrow's people with MSK issues. In Barking Dagenham, we're seeing more and more people in their 20s having inactivity and obesity-related MSK issues, for example, spinal deterioration. And these are major issues. We're seeing more and more in the deprived areas, especially people getting older age health conditions, especially around the MSK issues, 2 decades before people in the least deprived. And that's unsustainable for the people, never mind the health system. So that leads on to health inequalities in the NHS. We're not treated equally. We aren't. The least deprived areas, because people are healthier longer, the more resources. It's not just deprivation as I covered there, and you've got the snowball of health inequalities. I'll give an example. If you've got somebody who, and you'll know these as the people you represent as well, if you've got somebody who 2 years ago needed a routine hip operation because they'd reached a qualification, they would have qualified. Significant numbers of them were parked because there's no capacity in the NHS, and the NHS is dealing with critically ill people and COVID. And so people were pushed down the queue, and they're still in the queue. There were some people in 2-year queues in the NHS. You know yourself, somebody who is at the point where the NHS says you need a hip operation, and they're deteriorating from then, and have been in lockdown, they'll be suffering more issues. You're starting to look into mental health problems, because everything from isolation to loneliness to just persistent pain. And lots of conversations around how the mental health issues around persistent pain come in and how you help with that. And a lot of that could have been solved if the patient had had a hip operation 2 years before. But COVID is here. We've not done that. Then we've got how the NHS is funded. The NHS is funded in a way that it does tend to follow the ages. If you've got a significant amount of money comes based on age, but if you've got somebody who gets a health condition in a deprived area 2 decades before somebody in the least deprived areas, and you fund based on ages, well, how is the poorer area meant to cope? Then you've got the social care issues. If you've got a really deprived borough of London with really low council tax rates and no major businesses, rates and tax income to the local authorities reduced, so they don't have the money to put in either. Compare that to areas which have got lots of high value houses for council tax, or big businesses, or even big shopping areas. They could be quite deprived areas, but if they've got somewhere like Lakeside or Bluewater, they bring in quite a lot of local income as well. So the funding, there are health inequalities all over. And then, as was mentioned by Sarah, you can see the people further north, they have completely different health inequalities because they're not London. You can tell that by the responses to the storms and where places have still not got power. There is a difference, and it's all across the NHS. But how can you deal with this? We're talking individual here. How can we move on into helping individual people? So this is the main meat of my slide. What are we going to do to change that? We can't just sit back and do this. Every area locally has things that are coming in. I'll start with the first one, primary care networks, PCNs. For those of you who don't know PCNs, they're originally set as groupings of GP practices, geographical area, 30 to 50K, and their primary task is managing the footprint's health inequalities. They were set up in 2019, and from then till about now, they're building more and more. They're building the foundations of points in there. But for COVID, we would have gone to the points I'm going to discuss a year earlier. The things primary care networks will do with the health aspect and working wider is, from next year onwards, they're going to be expected to work wider and wider into communities through the points below. But it's how do we move on? How do we take it into an anticipatory care, personalised care, and move that towards prevention? And looking at these GP practices who know their people, working with extra resources that have been given them by the NHS, and all the different areas to look at how they can improve health inequalities. So, as overwhelmingly VCSE bodies with some healthcare people in here, find your local PCNs, talk to the PCN clinical director. What are they doing? What are your core? Do they know your requirements? Do they know the special problems that your demographic of your local people are having to contend with? Are they building it in? In primary care networks, they can bring in first contact physiotherapists at PCN level. And if you build it in, they can build it in future towards, if you've got an area that's got really high numbers of MSK issues, you could encourage and lobby the PCN CD to start diverting more resources towards that. We did a really useful exercise of all our PCN CDs. This is about 2 months before COVID really kicked off. And I asked each PCN practice to go through, and from the patient's perspective, from the frontline perspective, from the GP's perspective, to rank all the different issues and where there were gaps. And they were talking, every one of them had MSK in the top 3. Quite a lot of them had mental health from there, and then they linked them. And if you could help the PCNCDs to understand what they could do with extra resources and what help you need in working into the wider system, well, that's where you could focus and you could gain quite a lot of traction in there. Some people don't like going into the NHS though. So what more can you do? From April next year, integrated care systems go live as statutory bodies with the new bill that's going through. It will go through. The current goal is it starts 1st of April, and this is about 1.5 to 2.5 million population areas. Core goals of reducing and removing system level health inequalities. Sarah's presentation covered that excellently in so many areas of what they need to do. Now, that's there. In the two different bits of the integrated care system, you've got the integrated care board. That's overwhelmingly the NHS providers, but we'll have others on there as well. If you've got the integrated care partnership, though, this is a point where you do have resources. You can get VCSEs on there, and you should be lobbying hard to get your VCSEs on there as a group. Senior representations covering your whole system level. That's there. The next step down, place-based care. This is where I would like to lobby you to go and get involved in your local integrated care system. If you don't know what the place-based care is for your area, well, for London, it's the boroughs. The London boroughs, each one of those fits to place. And it's typically a geographically located body that's based on local authorities. So typically, if you're outside of London, it'll be your borough councils rather than your county councils. It works for us. For us, ours is Barking Dagenham, and we're developing a place-based care body there. This is us as the local face of the integrated care system, and it allows us on there. In ours, we've got multiple different VCSEs on our board. They're voting members of our board. We involve them in all the points you've talked before about co-production and everything else. They're involved. They come into the meetings. We involve them in all the meetings with the lawyers and getting this set up. We're designing our place-based care system from day one to include VCSEs, because how can you do integrated care without the people? We're not talking patients here, we're talking people. And this is where prevention comes in. If you bring in people early and right at the start, you can help influence this. If you can get people to understand in the NHS, who typically, the NHS does tend to be very silo focused, hospitals, mental health trust, community, GPs, they all have the little silos. This is what I do. If you can get them to understand, well, if you work between all these different groups, this reduces the need here, you're protecting the people, and by stopping people becoming patients, you save the NHS money, and that will get even the most hard-hearted of NHS finance person interested in this. This is where you as an individual can make a difference. So if you don't know who your local place-based care is, speak to your local authority, they'll know. Speak to your director of adult services or director of child services, they'll know. Speak to your director of public health, they'll know. If you know your PCNCDs, have a chat with them, they'll know. If you do not have at least one collaborative of VCSEs on your place-based care, this is what you need to be doing, because this is how you will influence health and social care in the future in the new statutory world. I'll present this and I'll send everything out there. There's some key resources here I'd like you to have a look at on there for if you want to find out more on how you as a VCSE can be more involved in place-based care. The legal view here is, well, that's the lawyer's view on how do you get involved, how do you get in there, how do you get on the ICS, and how do you get into place-based. The other two are more for information on there. So I'm going to stop sharing and I'm going to and I will hand back at that point.
Thanks very much, Craig. That was great. And again, lots of ideas there. I think we could have listened to that for much longer, but we've got 10 minutes left for questions now. We've got some some good questions in our question and answer box. We've had some really interesting chat as well. So I'm just going to take some of these questions now. Rob Yelton has got quite a long question here about some of the challenges to co-design. So I'm just going to pick a couple of those challenges that he's come across in other contexts and put them to you. So the first one I'm going to put is, if I can ask Amy, Rob's asking about involved groups being unrepresentative, which can often result in outputs which don't always resonate with others. How would you respond to people who put that challenge to you, Amy? Or how do we get more representative groups?
Yeah, thank you. So I recognise this challenge and would agree that this is something that has been sort of recognised quite a bit, that maybe involving people has not always been quite representative, and we do need to do better with this. So invest in people's knowledge, skills and confidence, sort of going back to that point, as that is something that in the development of ICS implementation guidance, I mean, sort of recognising that is aimed at ICSs, but it's also useful for trust and more sort of local levels. That's a really good way to support people, because recognising with work with people to strategically co-produce, there's some people who may never have done this before, and actually it's about supporting people and personally investing in people as well, but also just some of those more, I suppose, things that can be addressed within the system. So going back to the point just about when maybe asking for people to be involved, just be conscious about what you're asking for. So the point I made about people who are required to have board level experiences, what are you actually sort of looking for, I suppose, not aimed at you, but I suppose just thinking of things much widely, and actually just ensuring that we reach people. So building some of those community relationships is really key, and actually having just a really sort of clear offer and purpose, because some people may have been discouraged from co-production if they had a really bad tokenistic experience. They may not want to be involved again. So actually having that really clear offer of saying this is what we want to co-produce and why your lived experience would be really valuable within this, and recognising and valuing that lived experience as well. So there's a few systematic things, but also a few things to support people and invest in people as well. Hopefully that addresses some of the challenges, but it is a challenge that does need to be continuously addressed.
Thanks, Amy. That's a really comprehensive answer. Do either Sarah or Craig want to add anything there? You don't have to, because we've got other questions, so I'm happy to move on and come back. So I think some of the other questions will actually address this.
I thought Amy handled it really well. I can't really add too much to that.
I think Amy's managed to answer several of other points that Rob has in his list here, so that's great. But a question from Andrew aimed at Sarah. Sarah, Andrew's wondering about your thoughts as to whether the current approaches to addressing health inequalities are plasters or solutions, he asks, and how do we get them upstream to prevent rather than just reduce health inequalities?
Yeah, I think it's a good point. It depends where we look, doesn't it? And it depends on the approach we're taking. Some of the things Craig was nodding towards in terms of more upstream prevention is where we need to go with the solution. So often the approaches we're taking to inequalities are almost like your tertiary prevention in the NHS. So you're looking at actually how can we support people already living with this condition, whereas what we really need to be doing is looking at the inequalities in people becoming unwell in the first place, or inequalities in determinants of health, which often, if we're going really far back, lie in inequalities in opportunity in childhood. So opportunity to live a healthy childhood and a healthy life, and opportunities for things like good work. So they're the kind of fundamental things that I think we could do more to influence as health and care partnerships, and certainly a big something we're looking at in West Yorkshire, more work we can do with our combined authority, for example, on those determinants of health. But yeah, I think while some of it is a bit of a sticking plaster, I think we do still have people with inequalities with the conditions they're living with at the moment. So I think we need to be looking at that kind of whole pathway, but not focusing all our efforts on that kind of people who have already got the conditions, but looking a lot more upstream.
Thank you, Sarah. And relating to that idea of prevention, it's not really a question, but Debbie is saying there, and I think she's making a really good point, that as someone she has lived with JIA and also has a sort of child with JIA, how do you get young people involved? How do you kind of get young people to connect and to co-produce and to get involved in all those areas, co-production, prevention, taking more responsibility? That could go to anyone really who has thoughts on that one.
I'm happy to give this question a shot. So actually, part of my background was working with children and young people in involvement. And actually, there's a lot to think about. It's a different approach. So the British Youth Council have a lot of good resources on working with young people. And there's something different about this. So often when it comes to working with children and young people to co-produce, what we often sometimes see is a lot of the co-production may be happening during the day, and that's when children and young people are in school. So we actually need to go where the people are. So with children and young people, maybe setting up co-production sessions or involvement sessions in the evenings or weekends is just some really good ways to practically make sure that we're involving children and young people. But also just thinking about the language you use. Children and young people probably definitely not understand commission or may not have even came across that word before. So actually supporting people's knowledge as well. But also just making sure that young people have the opportunity, if there is maybe a parent or carer as well, to become involved. So actually maybe doing something quite collaborative. But for anyone who is interested in sort of working with children and young people more, definitely check out the British Youth Council, who do have quite a lot of resources about this.
Thanks, Amy, that's great, and a great link there as well. And we've got a couple of minutes left. I'm going to try and fit in another couple of questions here. Morris Cheng is asking everybody, how much work are you doing with environmental health in the local authorities, housing, etc.? This is a significant determinant of poor health and health inequalities. And does Waiting Well include this?
I could come in on this one. How we work with environmental health, it's a big issue for us, because in London, pollution, especially environmental health and working with it, is a major issue for us. And you see the furthering out of the ULEZ areas in London and the benefits it's having to people there. So you can see the involvement in environmental health. A lot of health and social care, and especially in the world of the integrated care, it's around the word care, and they don't look at, well, if you fix environmental health, you stop people needing care in the first place. So it's very much driven there, and it has to be part of the overall response in the new world towards prevention.
Thanks,
I
Craig.
come in as well, Jane, just to add to what Craig's saying. We are, I think it's it's an area that health needs to do more work with, and we're doing work again on the sort of climate change side of it and the air quality side of it, but also on the health and housing and safe housing and warm homes, particularly pertinent at the moment. So we've got kind of a joint project on warm homes, and again from MSK conditions in terms of people's quality of life, being able to kind of maintain a warm enough home in terms of in the winter time, but also where people are more likely to be in their home for prolonged periods of time, again really pertinent for people with MSK conditions. So both from a prevention point of view, but also from a quality of life point of view, it's really important. So the more we can do with our council colleagues, both environmental health and wider within local authority, the better, really, I think.
Thanks, Sarah. I'm going to just go over time for 1 minute to have a sort of chair's prerogative and ask one final question, because we're in pantomime season now. So if I were to give each of you one wish where you could have any change tomorrow in the NHS and social care, what would it be? Or can you think of one thing that you would like to change that you think would get everyone thinking differently? I'll go to Craig first.
Okay. The one change I could think with this audience in mind, I would like far more resources to be put into the social care aspects of health visiting, early health, child prevention, getting good habits, good nutrition, good health into people before they leave primary school.
Brilliant. I think we'd all agree with that. Sarah, can I come to you?
Yeah, mine was actually also linked to resource as well. Okay, it must be our kind of current mindset, but I think autonomy in terms of resource allocation, and what I mean by that is kind of based on that local need, but also allowing us really from an investment in health perspective to spend where we think we can have the biggest long-term impact.
Thanks, Sarah. And Amy, final wish for you. What would yours be?
I think it would be something to do with maybe governance and decision making, because if we're making decisions without people there, then how do we know we're making the right decisions? Because sometimes when we look at service improvement, sometimes the really good services are the ones that have listened to people, and the ones that often maybe fail or don't quite meet the needs, then they often haven't listened to people. So having something about decision making and ensuring that the voice of people lived experience is there.
That's great, and that's a really good note to finish on, I think. So getting people in early, changing people's attitudes early, but also sharing power and listening to people. So thanks to all our speakers this afternoon. I think they've given us some really fascinating things to take away, and we'll keep mulling over this and hopefully have a chance to talk again in the networking session. But now I'm going to hand back to Sue.
That's great. Thank you to everybody for that great session. So I'm just going to